Hello everyone, welcome to part 1 of our lecture series on the biomechanics of hip complex. In this session, we will begin by understanding the basic anatomy of the hip complex. We will discuss the bones that form the hip joint, the articular surfaces, the joint capsule, and the major ligaments of the hip complex, along with their structure and functional roles in maintaining stability. These concepts provide the anatomical foundation for understanding hip biomechanics and are essential before exploring joint movements, muscle function, and clinical applications. So, let's begin part 1 of the biomechanics of hip complex. First, the introduction of hip complex. The hip joint or coxofemoral joint is the articulation of the acetabulum of the pelvis and the head of the femur. These two segments form a diarthrodial ball and socket joint with 3 degrees of freedom: flexion or extension in the sagittal plane, abduction or adduction in the frontal plane, medial or lateral rotation in the transverse plane. This is an image of a hip joint. The hip joint is formed by the head of the femur and the acetabulum of the innominate bone of the pelvis. Next, the function of the hip joint. The primary function of the hip joint is to support the weight of the head, arms, and trunk both in static erect posture and in dynamic postures such as ambulation, running, and stair climbing. Next, about the structure of the hip joint. Proximal articular surface. The cup-like concave socket of the hip joint is called the acetabulum and is located on the lateral aspect of the pelvic bone. 3 bones form the pelvis: the ilium, the ischium, and the pubis. Each of the 3 bones contributes to the structure of the acetabulum. The pubis forms 1/5 of the acetabulum, the ischium forms 2/5, and the ilium forms the remainder. Until full ossification of the pelvis occurs between 20 and 24 years of age, the separate segments of the acetabulum may remain visible on radiograph. Here this image, the first image shows the acetabulum is formed by the union of the 3 bones of the pelvis with only the upper horseshoe shaped area being articular. And the second image, that's not an image, it's a radiograph. In this radiograph of a 2-year-old without impairments, the cartilaginous rather than bony union of the acetabulum is clearly evident. The acetabulum appears to be a hemisphere, but only its upper margin has a true circular contour, and the roundness of the acetabulum as a whole decreases with age. In actuality, only a horseshoe-shaped portion of the periphery of the acetabulum is covered with a hyaline cartilage and unarticulates with the head of femur. This is an image of a hip bone which shows the parts of the hip bone. The inferior aspect of the lunate surface is interrupted by a deep notch called the acetabular notch. The acetabular notch is spanned by a fibrous band, the transverse acetabular ligament that connects the 2 ends of the horseshoe. The transverse acetabular ligament also spans the acetabular notch to create fibro-osseous tunnel called the acetabular fossa beneath the ligament, through which blood vessels may pass into the central or deepest portions of the acetabulum. This image shows the hip or acetabular joint, open lateral view. It shows the ilium, acetabular labrum, acetabular fossa, pubis, transverse acetabular ligament, ischium, lesser trochanter, teres ligament, femoral neck, greater trochanter, femoral head, articular cartilage, etc. The first image shows the lunate margin and the acetabular notch, and the second image shows the ligament of the head of femur and the transverse acetabular ligament. The acetabulum is deepened by the fibrocartilaginous acetabular labrum which surrounds the periphery. The acetabular fossa is non-articular. The femoral head does not contact this surface. The acetabular fossa contains fibroelastic fat covered with synovial membrane. Next, about the center edge angle of acetabulum. Each acetabulum is oriented on each innominate bone somewhat inferiorly and anteriorly. The magnitude of inferior orientation is assessed on radiograph by using a line connecting the lateral rim of the acetabulum and the center of the femoral head. This line forms an angle with the vertical known as the center edge angle of Weber and is the amount of inferior tilt of the acetabulum. The center edge angles in adults to average 38 in men and 35 in women. This image shows the center edge angle, acetabular fossa, acetabular labrum. The center edge angle of the acetabulum is formed between a vertical line through the center of the femoral head and a line connecting the center of the femoral head and the bony edge of the acetabulum. The acetabular labrum deepens the acetabulum. Acetabular anteversion. The acetabulum faces not only somewhat inferiorly but also anteriorly. The magnitude of anterior orientation of the acetabulum may be referred to as the angle of acetabular anteversion. Average value to be 18.54 men and 21.54 women. Pathologic increases in the angle of acetabular anteversion are associated with decreased joint stability and increased tendency for anterior dislocation of the head of femur. Next, about the acetabular labrum. The entire periphery of the acetabulum is rimmed by a ring of wedge-shaped fibrocartilage called the acetabular labrum. The labrum is attached to the periphery of the acetabulum by a zone of calcified cartilage. It not only deepens the socket but also increases the concavity of the acetabulum through its triangular shape and grasps the head of the femur to maintain contact with the acetabulum. This image shows the gleaner acetabular labrum, acetabulum, femur and the head of femur. The labrum is not load-bearing but serves a role in proprioception and pain sensitivity that may help protect the rim of the acetabulum. Hydrostatic fluid pressure within the intra-articular space was greater within the labrum than we thought, which suggests that the labrum may also enhance joint lubrication if the labrum adequately fits the femoral head. The transverse acetabular ligament is considered to be a part of the acetabular labrum. It protects the blood vessels which reach to the head of femur. Next, about the distal articular surface. The head of the femur is a fairly rounded hyaline cartilage covered surface that may be slightly larger than a true hemisphere or as much as 2/3 of a sphere depending on body type. The radius of curvature of the femoral head is smaller in women than in men in comparison with the dimensions of the pelvis. Just inferior to the most medial point on the femoral head is a small roughened pit called the fovea or fovea capitis. The fovea is not covered with articular cartilage and is the point at which the ligament of the head of femur is attached. This is a posterior view of the proximal portion of the right femur, shows the relationship between head neck trochanterus and femoral shaft. The femoral head is attached to the femoral neck. The femoral neck is attached to the shaft of the femur between the greater trochanter and the lesser trochanter. The femoral neck is in general only about 5 cm long. The femoral neck is angulated so that the femoral head most commonly faces medially, superiorly and anteriorly. Next, about the angulations of the femur. There are two angulations made by the head and neck of the femur in relation to the shaft. One angulation is the angle of inclination occurs in the frontal plane between an axis through the femoral head and neck and the longitudinal axis of the femoral shaft. The other angulation, angle of torsion, occurs in the transverse plane between an axis through the femoral head and neck and an axis through the distal femoral condyles. First, about the angle of inclination of the femur. The angle of inclination of the femur averages 126 degrees, ranging from 115 to 140 degrees in the unimpaired adult. This image shows the axis of the femoral head and neck forms an angle with the axis of the femoral shaft called the angle of inclination. In this adult subject without impairments, the angles are slightly less than 130 degree with a couple of degrees of variation from side to side. In a woman, the angle of inclination is somewhat smaller than it is in men, owing to the greater width of the female pelvis. With a normal angle of inclination, the greater trochanter lies at the level of the center of the femoral head. The angle of inclination of the femur changes across the lifespan, being substantially greater in infancy and childhood and gradually declining to about 120 degrees in the normally elderly person. A pathological increase in the medial angulation called the medial angulation between the neck and shaft is called coxa valga, and a pathological decrease is called coxa vara. The first image is an abnormal pathological increase in the angle of inclination is called the coxa valga. The second image is a pathological decrease in the angle is called coxa vara. Next, about the angle of torsion of the femur and axis through the femoral head and neck in the transverse plane will lie at an angle to an axis through the femoral condyles, with the head and neck torsioned anteriorly with regard to an angle through the femoral condyles. A line parallel to the posterior femoral condyles and a line through the head and neck of the femur normally make an angle with each other that averages 50 degree to 20 degree in the adults without impairments. The femoral head and neck are in torsion anteriorly with respect to the femoral condyles. The angle of torsion decreases with age. In the newborn, the angle of torsion has been estimated to be 40 degrees, decreasing substantially in the first 2 years. In the adults, the normal angle of torsion is considered to be 10 to 20 degrees. A pathological increase in the angle of torsion is called the anteversion, and a pathological decrease in the angle of reversal of torsion is known as retroversion. This first image shows the angle of torsion, and the second image shows some parts, axis of head and neck, lateral condyle, axis of condyles, the angle of torsion. Abnormal angles of torsion in your right femur. A pathological increase in the angle of torsion is called anteversion. A pathological decrease in the normal angle of torsion is called the retroversion. Next, about the articular congruence. The hip joint is considered to be a congruent joint. However, there is substantially more articular surface on the head of femur than on the acetabulum. In the neutral or standing position, the articular surface of the femoral head remains exposed anteriorly and somewhat superiorly. In the neutral hip joint, articular cartilage from the head of femur is exposed anteriorly and to a lesser extent superiorly. Maximum articular contact of the head of the femur with the acetabulum is obtained when the femur is flexed, abducted and laterally rotated slightly. The acetabulum does not fully cover the head superiorly, and the anterior torsion of the femoral head exposes a substantial amount of the femoral head's articular surface anteriorly. Articular contact between the femur and the acetabulum can be increased in the normal non-weight-bearing hip joint by a combination of flexion, abduction and slight lateration. A slight lateral rotation. This position, also known as the frog leg position, corresponds to that assumed by the hip joint in a quadruped position and is the true physiological position of the hip joint. And in this image, an infant can easily be maintained the hip joint position of flexion, abduction and external rotation by using a positioning device. Next about the hip joint capsule and ligaments. Hip joint capsule. The hip joint capsule is a substantial contributor to joint stability. The articular surface of the hip joint is an irregular, dense, fibrous structure with longitudinal and oblique fibers and with three thickened regions that constitute the capsular ligaments. The capsule is attached proximally to the entire periphery of the acetabulum beyond the acetabular labrum. This image shows the joint capsule, synovial membrane, fluid-filled synovial cavity, ligamentum teres, labrum, joint capsule, femoral head, cartilage, labrum, etc. The capsule itself is thickened anterosuperiorly where the predominant stresses occur. It is relatively thin and loosely attached posterior-inferiorly. The capsule covers the femoral head and neck like a cylindrical sleeve and attaches to the base of the femoral neck. The femoral neck is intracapsular, whereas both the greater and lesser trochanters are extracapsular. The synovial membrane lines the inside of the capsule. Anteriorly, there are longitudinal retinacular fibers deep in the capsule that travel along the neck toward a femoral head. The retinacular fibers carry blood vessels that are the major source of nutrition to the femoral head and neck. The retinacular blood vessels arise from a vascular ring located at the base of the neck and formed by the medial and lateral circumflex arteries. Next about the hip joint ligaments. The first ligament is the ligamentum teres. It is an intra-articular but extrasynovial accessory joint structure. The ligament is a triangular band attached to one and to both sides of the peripheral edge of the acetabular notch. This image is a frontal section through the right hip joint. Here are some parts: articular cartilage, acetabular labrum, femur, ligament, head of femur, synovial cavity, articular surface. The ligament then passes under the transverse acetabular ligament to attach at its other end to the fovea of the femur. Thus, it is also called the ligament of the head of femur. The ligamentum teres is enhanced in a flattened sleeve of synovial membrane so that it does not communicate with the synovial cavity of the joint. It is tensed in semiflexion and adduction. It's an anterior view of your right hip, shows the centrally located ligamentum teres arising from the fovea on the femoral head. The joint capsule and other structures may have been removed. The ligamentum teres appears to function primarily as the conduit for the secondary blood supply from the obturator artery and for the nerves that travel along the ligament to reach the head of femur through the fovea. The hip joint capsule is typically considered to have three reinforcing capsular ligaments, two anteriorly and one posteriorly. The two anterior ligaments are the iliofemoral ligament, the pubofemoral ligament. The one posterior ligament is the ischiofemoral ligament. The iliofemoral ligament, it is a fan-shaped ligament that resembles an inverted letter Y. It often is referred to as the Y ligament of Bigelow. The apex of the ligament is attached to the anterior inferior iliac spine, and the two ends of the Y fan out to attach along the intertrochanteric line of the femur. The superior band of the iliofemoral ligament is the strongest and thickest of the hip joint ligaments. It's an anterior view of the right hip joint. Shows the two bands of the iliofemoral ligament and the more inferiorly located pubofemoral ligament. Next about the pubofemoral ligament, it is also anteriorly located, arising from the anterior aspect of the pubic ramus and passing to the anterior surface of the intertrochanteric fossa. The bands of the iliofemoral and the pubofemoral ligaments formia is that on the anterior capsule. Next about the ischiofemoral ligament, it is the posterior capsular ligament. Ischiofemoral ligament attaches to the posterior surface of the acetabular rim and acetabulum labrum. Some of its fibers spiral around the femoral neck and blend with the fibers of the circumferential fibers of the capsule. Other fibers are arranged horizontally and attached to the inner surface of the greater trochanter. This is a posterior view of your right hip joint shows that the spiral fibers of the ischiofemoral joint are tightened during hyperextension and therefore limit hyperextension. The hip joint capsule and the majority of its ligaments are quite strong and that each tightens with the full hip extension. The anterior ligaments are stronger than the ischiofemoral ligament. Under normal circumstances, the hip joint, its capsule and ligaments routinely support two-thirds of the body weight. In bilateral stance, the hip joint is typically in neutral position or slight extension. In this position, the capsule and ligaments are under some tension. The normal line of gravity in bilateral stance usually behind the normal line of gravity in bilateral stance falls behind the hip joint axis, creating a gravitational extension moment. This example, this diagram shows the lumbo-pelvic rhythm, hip-knee angle joint axis, center of mass. Thank you for watching part 1 of our lecture on the biomechanics of the hip complex. In this session, we discussed the basic anatomy of the hip complex, including the bone, articular surface, joint capsule, and the major ligaments that contribute to the stability. These anatomical concepts provide the essential foundation for understanding the biomechanics and functional movement of the hip. In part 2, we will continue with the movements of the hip joints, osteokinematics, arthrokinematics, muscle function, and their clinical significance. Thank you for your time and attention.